of cases which are different causes to an alarm plan. It's very important to be aware of. So my talk is divided into the following sections. Start by block. And so published data, normal and being tracked, and then anomalies which may be difficult to detect, and then megacystis. Then I'll talk about cystic renal disease, and then I'll finish up with abdominal wall defects, with then some summary of comments. So this is a study of 100,000 pregnancies, published back in 2019. And when you look at the detection rate for kidney abnormalities, you can see that the fact in the first semester that it was very low for all of these conditions. So in a sense, I feel that we need to improve in our detection rate of genital urinary tract abnormalities. And I want to share with you some clues today as to how we can improve. So this is a grouping of all the abnormalities that we've always seen, sometimes seen, infrequently seen, and seldom seen. Now, relating to the GUT, lower urinary tract obstruction, we can pick up 2/3 of these. With a group of multicystic kidneys, hydronephrosis, duplex schism, and unilateral regenesis, our detection rate is only 30 to 50%. And then for bilateral renal disease, it's less than 30%. I think every woman who's pregnant wants to know if their baby has got a lethal abnormality. Bilateral renal agenesis is a lethal abnormality because they end up with severe pulmonary hyperplasia. And in a sense, we regard it, when you detect in the first minute, we regard it as being a very important abnormality to detect. But why do we detect so few babies with bilateral renal agenesis? Babies with bilateral multicystic dysplastic kidney disease. Babies with bilateral polycystic kidney disease, Mecklenburg syndrome. Why are we so bad at picking up these? Because I believe we can do so much better. And I have one take-home message from the talk today, is never go home without seeing the urinary bladder. So for every pregnancy that you scan at 13 weeks, if you are scanning and you don't see the bladder, don't move away and close the books and send the patient home. You must wait until the bladder fills, because it will fill during your examination. Because if it doesn't fill, the baby may have bilateral renal disease, may have bladder exstrophy, may have cloacal exstrophy. And these are difficult diagnoses of which I will give you some clues today on how to make them. As I said to you, for monogenic disorders, for renal disease, it's only 3 to 5%, so it's a very low need. If we start with a normal renal tract, be careful because the baby's kidneys are quite hypertonic in the first trimester. Only after 13 weeks of gestation do they take on the same ectotexture and bladder. So be careful about calling polycystic disease before 13 weeks. They can look hypertonic, especially with the 3D technologies, with volume contrast imaging and volume speckle reduction imaging. But these are not abnormal kidneys, these are normal. So be careful with the new technologies, they may lead you to misinterpret the appearance of kidneys when they are hypertonic. For the next case you will see, if you are struggling tomorrow morning to find the kidneys, look with color Doppler examination. Because with color Doppler examination, you can see the renal arteries. And then you have peace of mind, yes, the kidneys are present. In 30% of the cases, you will see more than one renal artery. In this baby, you can see that there are 2 renal arteries, and there's also a suprarenal artery. This is a known common variation. There are 500 people in this room. 150 of you have a variation in your renal artery anatomy. And we can see that on babies on scan prenatally. If this is a patient that you go tomorrow to scan in your practice, and you see this picture, and you're seeing the umbilical arteries, and there's no bladder in view, we should never let that patient go. Never. Because if I see a bladder empty like that at 30 weeks, I start making diagnoses. So I start examining the brain, the heart, the hands, and I come back to the bladder. And this is minutes later on this patient. This is 11:26, this is 11:31. So minutes later, the bladder filled. But if minutes later the bladder doesn't fill, you need to raise the alarm. With regard to looking at the kidneys, the cutoff for renal pelvic dilatation is 1.5 millimeters. If it's more than 1.5 millimeters, then the patient has got panectasis. And you say, don't worry about panectasis. I said, no, you've got to take panectasis seriously. It's a marker for dancing, for other chromosomes not to mind. It's a marker for urinary tract obstruction. It's no problem if it's isolated. When it's not isolated, then there's a problem. So if I see that it's isolated, I'm okay. If I see the marker of anti-growth, I can operate in that test. I then look for urinary tract obstruction, and then I can see the syndrome. So don't disregard unilateral salutation. This is a patient of 13 weeks and 4 days with a thin leukocytosis. And when I look at the kidneys, I can see that there's bilateral renal pelvic dilatation. And when I went to look at the heart of the same baby, I could see that there was tricuspid valve regurgitation. Now I have two markers, renal pelvic dilatation and tricuspid valve dilatation. And this is the disease of trisomy 21. So treat it seriously when you see renal pelvic dilatation. In this case here, you can see renal pelvic dilatation. The reason there's renal pelvic dilatation is because there's urinary bladder obstruction. In fact, it's likely that you see lower urinary tract obstruction neutral first before you see renal pelvic dilatation. What about duplex renal system? Two on this side and two on this side, or one on that side. It may be isolated. It may be associated with other markers. It may be associated with genital urinary tract abnormalities, or may be associated with syndromes. When you're scanning this baby on the left-hand side, you will see here when you look at the kidneys that there are two renal pelvises. And if I see two renal pelvises, I then look to see the opposite kidney, see whether there's one here. I compare this kidney here to the kidney where there's a duplex system, and I look at this kidney here and see two renal pelvises. When I see that there are two renal pelvises in that kidney, I then start to ask myself what else is going on? I then consider using 3D because sometimes you can think there are two renal pelvises, but there's only one. It's easy to make a false positive diagnosis. Then I use 3D and see the kidney on this side, the two renal pelvises, and one renal pelvis. I'm convinced that this is a duplex system. This is a baby who's got a thin leukocytosis, a normal native bone, 13 weeks and 4 days. When I scan this baby, I see that the fourth ventricle is dilated. I see that there's hypertelorism. I see that there's a duplex renal system, and there's a single umbilical artery, and there's polydactyly. There was nothing else in this baby. Normal brain, normal heart. It had 4 markers, of which a duplex system was part of that marker. Again, when you see an isolated marker, go looking for more. What about a horseshoe kidney? Yeah, that could be isolated. It could be with other markers. It could be with genital urinary tract anomalies or syndromes. When you are scanning across with color Doppler and you cannot see the renal arteries, and if you think the kidneys will be very close together, you should suspect horseshoe kidney. It's a very difficult diagnosis in the first semester of pregnancy. When you look at 3D static, you can now appreciate there's a single kidney going across the midline.
be volume spectral reduction imaging or volume contrast imaging, and this may outline for you more clearly the appearance of the kidney and the sinusoidal kidney. When I see that, I then ask myself, what else is going on? And I see a tiny omphalocele minor. And I also, when I look at the heart, I see that the left cardiac ventricle is smaller when compared to the right, and the structural valve compared to the patient. This is the baby proportion kidney, two other markers, that's got trisomy 18. To treat proportion kidneys seriously. When you look at this baby here, you see a single renal artery going to this, but this renal fossa is vacant. There is no visible kidney on the other side. And this is a difficult diagnosis in case of unilateral renal agenesis. If you ever think you've got unilateral agenesis, look down at the region of that, because it may be impelled kidney. In this case here was a fetus which shows no urinary bladder visualized at 12 weeks and 4 days. And if you scan across from this baby on the right hand side, you see that the renal fossa are vacant on the left and vacant on the right. Bilateral vacancy of the renal fossa, absence of fluid in the bladder, and all we could see was two cystic structures in the bladder, but no urine production. And this is the baby at 18 weeks with anaphylaxis. Babies who've got bilateral renal disease, who've got no kidneys, will have normal lipovolume at the first trimester, because only a tiny amount of fluid comes from urine. How many weeks gestation will there be no fluid surrounding the baby? 18 weeks gestation is when anaphylaxis presents. So it's a late diagnosis if you rely on amniotic fluid. You cannot rely on amniotic fluid. I want now to talk about megacystis. If you look at megacystis, there are many different associations that exist. And this is across 541 cases of megacystis from the Netherlands between the first and the third trimester of pregnancy. Half of these before 18 weeks and the other half after 18 weeks. About 7% of these will have a chromosome abnormality. About 1% will have microdeletions. About 6% will have colorectal malformations. About 5% will have overgrowth syndromes, and others will have monogenic disorders. That paper, when it was published, was so important to me because it made me think about how I counsel and manage a patient with megacystis in the first semester of pregnancy. This is a group from Paris, which is the largest reported series of megacystis in the first semester of pregnancy. 75 cases. And when you look at the 75 cases, 84% of these have adverse outcomes. Figures are terrible. When the bladder is larger than 12 millimeters when they cut off this study, you have a terrible prognosis. And only 60% of these are related to obstruction. The other 40% may be syndromic problems, megacystis, microcolon, intestinal hyperperistalsis, Cruden-Deli syndrome, and other monogenic disorders. So you go to work tomorrow morning and you see this. It's a terrible prognosis. The maximum bladder measurement is around 3 centimeters, 30 millimeters in a male fetus. For most patients, when they are counseled about the outcome, they choose not to continue because the renal prognosis is so poor. We look to see if there's hyperepigenic kidneys, if there's evidence of early cystic renal dysplasia. We recognize that that's challenging in the first semester of pregnancy, but we still look for it. In the case of here, another 2 cases of fetus with grossly dilation of urinary bladders, again, well more than 50 milliliters. On the left-hand side was a case of megacystis, microcolon, hyperperistalsis, and in this case also an anorectal malformation. So remember, it has counseling these patients on maybe more than what you think. What about you go to work tomorrow morning and you see a bladder measuring 8 milliliters? Well, that's megacystis because it's more than 7. So when it's more than 7 millimeters, we offer CDS. We do a chromosomal micro, and then we review the patient 2 weeks later. We know that 80 to 90% of these that are between 7 to 12 millimeters, some say 7 to 15 millimeters, will resolve as the pregnancy progresses. And also be very careful. When you think you are looking at megacystis of 9 millimeters, be careful that you're not looking at a pelvic cyst. It could be a mesenteric cyst, an ovarian cyst, and the only way of being sure by looking at color Doppler examination is to see that both arteries go either side. Now you know it's megacystis. CDS, wait 2 weeks, review it. And if you see a bladder looks like this, which is even more than 9 to 10 millimeters, this is the same patient, and you look at it here, 2 weeks later, the bladder is back to completely normal. Why does that happen? We believe it's delayed innervation of the urinary bladder that causes that to happen. So, when I see a patient 12 weeks with megacystis, I offer boron biopsy. I consider the differential diagnosis of urethral atresia and the chromosomal abnormalities. I check for an anomalacia, for chronic abnormalities, I check the spine, and I offer CDS. It is very important that I see this patient again, because I want to know, do they have hydramnios? And that's if they have normal lipovolume of megacystis, you should make me think about megacystis microcolon. And then I need to look at the spine. And if the baby is macrosomic with a big bladder, you need to consider Beckett-Levin syndrome and Sotos syndrome, and you need to consider extra So the story is not finished when you have a normal chromosomal microarray in the setting of a persistent enlarged bladder. You need to check this. And remember, when counseling patients, when a patient sees that there's a large bladder and wants to continue the pregnancy, remember 15% of these result in spontaneous death in utero. This patient came to see me because she wanted me to discuss with her putting in a shunt. The prognosis for putting in shunts and obstructed bladders is not good, but she wanted to speak to me. So when she came to see me with megacystis, there was no heart motion in the baby. Because 15% of babies with megacystis in relation to utero die in utero. So I'm going to put you to the test. And this is a patient that you see tomorrow morning. And I want you to tell me, what do you think is going on? The first thing you do is you see megacystis, what looks like a dilated urinary bladder, and you see the kidneys with pylectasis. You see the dilatation of the proximal urethra. And once you see that keyhole deformity, you are straight in the diagnosis of posterior valve syndrome with renal dilatation. Is this a baby with posterior urethral valve syndrome? Yes or no? No. This baby does not have posterior urethral valve syndrome. It makes it show you how easy it is to get a diagnosis wrong. Because when you look at this baby, that's its urinary bladder. And sitting behind the urinary bladder, that's the rectum. And what you're seeing here is a dilated sigmoid colon and a dilated rectum. So when you're seeing that there is a megacystis, you need to look at color Doppler examination to see that you have a normal bladder. Don't jump to the diagnosis of this being a megacystis. In fact, anal rectum increasing. And remember what I said about anal rectum increasing. Remember for these that there's a common association with megacystis and it's a very important differential diagnosis. What about this baby? So this baby strange looking bladder because the walls are so thick. Yes, the bladder walls can become very thick, but not like that. When you look at this on sagittal section, you can appreciate that this has got a very elongated appearance to it. And this is in fact a hydrometra, hydrocolpos, in the setting of renal pelvis dilatation. You are likely to have a connection. And this may be part of a rectal septum where you've got the genital urinary tract connecting with the gastric dilatation. When you look at sagittal section of this feature, again, a strange appearance. Megacystis tend to be more spherical. But this is in the shape of a dilated uterus, not a dilated urinary bladder. A hydrometra and colpus. I'll finish up with cystic kidneys. The features that I showed you earlier today with the nephrocele and bilateral cystic kidneys. When I see that picture of a baby with a thin nucleus of lucidity, cystic kidney disease, the first thing that I look at is not the brain. First thing I look at is the hands and the feet. And then I go on to looking at the rectum. And the same baby, polygastric feet, all the typical appearances of Necker-Brewer syndrome, which is a monogenic disorder, and there are several gene mutations which may give rise to this condition. You may also appreciate cystic renal dysplasia when you look at this. This is the features of dilated seal dilatation. And when you look at the kidneys, you see punctate tiny area of punctate calcification. These are the typical appearances of cystic renal dysplasia that are related to chronic obstruction. And most of the data that relates to ultrasound predicting cystic renal dysplasia is in the second trimester. Very little detail on this in the first trimester. I still think it's worth looking. With regard to multicystic dysplastic kidney disease, I'm sorry I have nothing but bad news for you, because this is a condition we generally cannot pick in the first trimester of pregnancy, unless it is bilateral. Even if it's bilateral, then you can pick it up by seeing no urine in the bladder. The problem is with these, for many of them, no urine in the bladder happens later in the pregnancy. Have a look at this patient that I saw at 14 weeks of gestation and tell me, do you think there's something suspicious? Because what we looked at when we looked at these kidneys is we could not see the normal morphology of the fetal kidneys. They looked to be like tiny little cysts on the kidneys on each side. I didn't know whether this was normal or abnormal. I thought when I looked at the lipovolume that maybe the lipovolume was subjectively reduced. She was 14 weeks of gestation, and I knew there was no published data on multicystic dysplastic kidney. So this was on the 28th of August. When I see her 2 weeks later, on the 7th of September, she now demonstrates all the features that are absolutely typical of multicystic dysplastic kidney disease. I can see here the old individual renal cyst, and now I can see a very obvious reduction in the lipovolume. There still is lipo there, but by 18 weeks, remember, there will be antigranules. So that's the earliest in which we pick up bilateral multicystic kidney disease. And I still feel it's a difficult diagnosis. We reported the first case in the world literature of unilateral multicystic dysplastic kidney disease that was confirmed post-natal. We published that in a white journal many years ago. But that's the only case that exists in the literature. Patent urachus, you need to be careful of patent urachus because quite frequently you say, that's an umbilical cord cyst, and in fact it's not an umbilical cord cyst. It's a patent urachus. And you need to be very careful because when the baby is born, you do not want to clamp a urachal cyst. You can very easily make a misdiagnosis. This is the urinary bladder. That is not an umbilical cord cyst because there's a communication here between the bladder and that cyst. And you may see in some degree signs of obstruction. And if you look at here, renal pelvis dilatation was the first clue that made me think that in fact it's not a cord cyst, but in fact I'm looking at a urachal cyst. Another case when you look at sagittal section, you can see there's a communication. But the communication was more easily seen when you look at the axial section, where you can see tracking the umbilical artery either side of the line, you can see the defect connecting the urethral system and bladder. And also, to distinguish a cord cyst from a urethral cyst, you have to see the two umbilical arteries going around the urethral cyst. Two umbilical arteries do not go around the umbilical cord cyst. That's another very helpful. So when I see this baby with megacystis, I'm asking myself the question, is that a cord cyst or is that a urethral cyst? And I'm looking here, watching to see whether the bladder changes in size or whether the urethral cyst changes in size. If there's no communication and there's no change in size, then that is an umbilical cord cyst. Lastly, I will finish with bladder extricating with program extricating. These are extremely rare conditions. Isolated bladder extricating is the least severe form, but they still carry terrible problems because of problems with reconstruction of the external genitalia, which is terribly traumatic for parents. When you do a scan at 13 weeks and you see a tiny little ribble below the level of the umbilical cord, that's going to be a bladder extrication. Most of these are missed on prenatal imaging. Why? Because you went home without looking for a urinary bladder. If you have bladder extricated, there's no visible urinary bladder because the bladder is inverted. And the second finding is the cord should be inserted here, but instead the cord is inserted very low. Low cord insertion, no visible bladder, and a tiny ripple below the cord insertion site are the three diagnostic markers for bladder extrication. Then there are the rarer abnormalities where you may have a cloacal cyst, vallocele, spinal defects as part of the OIES complex. And I spoke about these this morning. So in summary, with regard to genital urinary tract malformation, I think we can improve. I think we need a targeted assessment of the kidneys. We need to empower doctors to see the renal arteries. We need to take renal pelvis dilatation seriously. We need to look routinely at the bladder and lower artery bifurcation. You need to be suspicious about umbilical cord cysts, and you need to examine the